This topic is the non-transplant option for aplastic anemia. Professor Mothy, please.
Good afternoon. Once again, thank you very much for the kind invitation. It's a pleasure to be part of this distinguished panel. It's always very interesting for a transplanter to do from time to time a review about non-transplant results. I didn't choose the topic. I have been asked to speak about it. So initially I thought there was a mistake in the title, but then I was confirmed that I should speak about non-transplant. Okay, so it has been recognized actually for several decades now that aplastic anemia is a dysimmune disorder where there are several mechanisms leading to the immune destruction of hematopoiesis. Very recently, there have been accumulating evidence about the role of cytotoxic T cells in this process. Initially, Th1 cytotoxic T cells were described, but more recent data from NIH highlighted the deleterious role of Th17 cells. All of this leading to a sort of activation and destruction of the normal hematopoiesis. This is the reason why immunosuppressive therapy has been thought for a long time to be a standard of care in aplastic anemia. And more than 10 years ago, it has been shown very nicely that over the long term, this is a study with more than 11-year median follow-up, over the long term, ATG and cyclosporin is a standard of care in those aplastic anemia patients not eligible to allogenic stem cell transplantation. And when we look to the major and most important studies from the literature, whether from the German cooperative group, from NIH, EBMT, Japanese group, NIH, and so on, you can appreciate that there is an overall response to ATG and cyclosporin around 60%. And when looking to survival, even in the oldest series, the results are quite fair and very interesting over the long term, ranging from like 55 to 85% survival. However, one must acknowledge that when it comes to immunosuppressive therapy in aplastic anemia, not all patients are equal. For example, it is well established there is a significant impact of the disease severity. Obviously, those patients with severe aplastic anemia are going to do less good than the standard aplastic patient. Age also in this disease has been very well established to be a prognostic factor. The older patients are going, unfortunately, to behave more poorly than the youngest patient, and the threshold around 20 years have been demonstrated in several studies. Also, another major feature of immunosuppressive therapy in aplastic anemia is the impact of year of treatment. This is a disease where it has been very nicely established that there has been lots of progress over time. And when you compare the early period, for example, the early 70s, the 70s and early 80s, versus the most recent period, there is a very nice, significant difference, and I believe these results keep on improving over time. From a pathophysiology perspective, there is also, for example, an impact of the presence of a PNH clone in terms of response and so on. But I will not expand on this because this is out of the scope of this talk. So, ATG plus cyclosporin is the standard of care. And the question, can we do better than ATG plus cyclosporin? And that was the idea behind several trials. The first logical option that was tested by EBMT was the use of GCSF, because obviously these patients have leukopenia, so you might expect some benefit when adding GCSF. Unfortunately, the randomized phase 3 trial from EBMT did not show any significant advantage for adding GCSF to ATG and cyclosporin, and therefore, except for few specific cases, GCSF is not used routinely in combination with ATG and cyclosporin. Another option, and this has been pioneered by the Johns Hopkins group, is the use of cyclophosphamide. I mean, cyclophosphamide has been shown for almost 40 years now to have some important and interesting immunomodulatory properties, especially the capacity of cyclophosphamide to target and destroy alloreactive T cells. And this is the idea behind the expanding use of cyclophosphamide these days in the haplotransplant field. So the Johns Hopkins group published their experience using cyclophosphamide alone in aplastic anemia. The results are quite interesting. However, one must acknowledge that based on these results, we cannot recommend cyclophosphamide alone as a standard of care in this disease. Another controversial and very important topic that has been tackled in the recent years is the use of rabbit ATG versus horse ATG. Traditionally and historically, we used to use horse ATG, namely lymphoglobulin, or ADGAM. The NIH group performed a randomized phase 3 trial comparing horse ATG to rabbit ATG. And the results were quite interesting and quite surprising, because this randomized trial showed that the use of rabbit ATG is correlated with a lower outcome compared to horse ATG. And this is the reason why in many places there is a recommendation to use, whenever possible, exclusively horse ATG in this disease. However, one must acknowledge that this data remain under hot debate, I would say. Because if you look to the Spanish data, and one major issue in the NIH data is the relatively poor response rate in the rabbit ATG arm. So for some reason, the patient in the NIH trial in the rabbit ATG arm did not respond very well. Whereas in the Spanish registry-based data, the response rate was shown to be around 60 to 65%, whereas it was only around 35% in the NIH data. Also, so you can see here the objective response rate. It's comparable between the horse ATG from the Spanish data versus the NIH data. But when you look to the rabbit ATG arm, you can appreciate it's around 70% in the Spanish data versus only 35%. So we do not have a clear explanation to these differences. Also, if you look to the Italian data, again, this is in line with the Spanish data in contrast to the NIH data. Looking to experience from Houston, again, you have a response with rabbit ATG around 60%. Cleveland Clinic, it's also the same story. And even in the Asian population, because one might expect that there might be some genetic polymorphism and things like this. And as you know, the incidence of aplastic anemia is higher in this region of the world compared to the Caucasian population. But still, for example, in the Korean experience, the response rate with rabbit ATG is similar to the Caucasian European data. We have the same data in the Chinese population. This is a children population. Again, this is from Korea. For the sake of time, I will, this is the Japanese experience, also showing a comparable response rate between rabbit and horse ATG. So why are all these differences? I think this is work in progress. I couldn't find a clear answer how to explain these different discrepancies. Nevertheless, one must admit that the mechanism of action of horse ATG versus rabbit ATG is probably very different. You can appreciate here, just looking at a very simple parameter, which is the absolute lymphocyte count, that the two products do not behave the same. So we still need to learn and understand how these agents work. Finally, are we stuck with ATG and cyclosporin? I don't believe so. There are lots of hope about the use of L-Trombopag. So L-Trombopag, you heard already about it during the day. This is a very promising and interesting agent, already approved for other indication. And you may have seen this very nice paper, again from the NIH group who pioneered this work, using L-Trombopag in 25 refractory patients. And actually, the use of L-Trombopag is appears to be a very promising and interesting agent. And currently, I believe there are some planned or ongoing randomized trial to establish whether ATG plus cyclosporin plus L-Trombopag could represent in the near future a standard of care in this disease. So in conclusion, I think aplastic anemia management is quite well known worldwide. We definitely, all of us would agree that we need to avoid wasting time after diagnosis to start therapy. So supportive care and management of these patients is very important. The estimate on when to assess the response is very important, because at some point one would need to decide on a second-line therapy. Usually 3 to 4 months is a minimum. Because of the long-lasting lymphopenia and leukopenia in these patients, we need to prevent and control effectively early infections. One should be very careful about the use of steroids, especially because they are used at high doses because of ATG. Prophylaxis, although there is no, I think, universal consensus, but antimicrobial prophylaxis should be used in a wise fashion. And we'll hear later on in the session probably about the algorithm on how to decide, but this is relatively, I would say, simple, whether it's 40 years or 50 years before considering transplant, if they have a sibling donor or not. It can be a matter of debate, but I think for the sake of time, I will skip this. And without any further delay, I would like to thank you for your attention and again highlight these events where you are all kindly invited. Thank you very much.